Right. So I want to acknowledge that many of us today are on the unceded and ancestral territory of the Coast Salish peoples. That includes the territories of the Musqueam, the Squamish, and the Tsleil-Waututh nations, as well as the Métis Charter community of the Lower Mainland region. And wherever you are throughout Turtle Island or this province, acknowledging and appreciating the land and the people on it and learning and committing to that learning is of tantamount importance. I think all are attempting to reflect about our positions and our relationships with the land and the peoples. Next slide. So Province-Wide Rounds is a collaboration between the University of British Columbia Division of Nephrology and BC Renal. It's supported by a number of different industry partners and all of you in the different health authorities. And I think all of us endeavoring to ensure that we have the most up-to-date information with which to improve our learning, but also make sure that we take the best care of patients in the moment. Next slide. So it's a pleasure to introduce Dr. Navdeep Tangri, who's an attending physician and professor in the Division of Nephrology at the Department of Internal Medicine and Community Health Sciences in the Rady Faculty of Health Sciences at the University of Manitoba. Many of you will know, but Dr. Tangri's research program is multidisciplinary and focused on improving clinical decision-making for patients with or at risk for chronic kidney disease. The KFRE, he was developed and validated by Dr. Tangri that predicts the need for dialysis in people with CKD. And he's been a member of multiple guideline groups, and it consults and engages with lab providers and electronic medical records to help increase the uptake of prediction models. Over 400 manuscripts, a national and international leader in clinical prediction modeling, and a nominated champion of the American Society of Nephrology efforts on AI and kidney health. So with that, over to you, Nav, and looking forward to your latest passion, which is moving upstream. So over to you.
Thank you, Adira. Thank you for the very kind introduction. I'm really delighted to present in sort of Kidney Week, World Kidney Day, and exactly as Adira said, my latest passion, which is really about moving upstream. So why do we need to move upstream? Moving upstream is not relevant prior to 2015 when you only have RAS inhibitors, but moving upstream is paramount now because we have multi-drug therapy for treatment of chronic kidney disease. And I think you'll agree that if we move upstream and we treat these patients before kidney function is lost, we can have the maximal impact. These are my disclosures. So today, how we deliver care is largely based on eGFR. Two people with the same eGFR get the same care, no matter where you are, whether you're in Canada, US, or Western Europe. People with an eGFR of 30 get recognized as having advanced kidney disease, and people with an eGFR of 70, regardless of whether they have blood or protein in the urine, unfortunately, get treated as if they're doing just fine. And we've made major strides in kidney disease. I mean, I think 20 years ago, as I reflect, we would still be talking about creatinine and CRF, and half of Canadians wouldn't be diagnosed with chronic kidney disease because their creatinine was normal. So yes, we've improved, but we're stuck in eGFR. And if you think about these two people who have an eGFR of 30 or 70, perhaps one of them is high risk for progression and the other one is low risk for progression. And the high-risk person gets undertreated and the low-risk patient gets overtreated. Now, I think a lot of us use the KFRE in later stages of kidney disease, but we don't really use anything in earlier stages, and there's a need there as well. When I have conversations with payers and health systems and people outside of nephrology, they're even more stuck in eGFR. So if you talk to large US payers, for example, they only think about dialysis. Dialysis is the only outcome they care about because it's so catastrophic. But they fail to realize that the journey from eGFR of 90 to 100 to 30 to 45 is filled with heart failure hospitalizations and CKD progression, which is costly and harmful. And finally, we have a number of sponsors who've made highly effective drugs for chronic kidney disease, but they're not reaching patients with CKD because patients are not recognized as having CKD. So if people think you're doing fine because your eGFR is fine, you don't get treated. And my thesis in my entire program has been that a risk-based approach can transform CKD care. One of the best things that I ever did in my career, and sometimes these Kidney Day talks can be a reflection of one's career, was participate in the KDIGO guidelines. It was a lot of work, but I think that it's an incredible work product. And one of the things I'm most proud of is the inclusion of estimation of risk of progression as an essential part to the management of CKD. I think many of us who work in doing research and generating evidence-based practice think that we'll critically appraise every article or we'll make really evidence-based decision for every patient. But the vast majority of providers in the world, clinicians in the world, actually really rely on the KDIGO clinical practice guidelines. And I'll share a little anecdote here today that one of my colleagues from Germany reached out to me last week, and they said, "Oh, I've been talking about KFRE for years, but now it's totally caught on in Germany." And I said, "Oh, really? That's great." And he said, "It's because the KDIGO guidelines came out with a 1A recommendation, and the Germany primary care guidelines took that recommendation and added it to the primary care framework." So guidelines really matter. So I think if for any of the people in the audience, if you ever get an opportunity to participate in a guideline, I would do it 100 times out of 100. These are some of the key recommendations from the KDIGO guidelines. So not only is there recommendation about KFRE and a 1A recommendation to use an externally validated risk equation, there's these thresholds which have been used in other places, and I'll share some data on that. And also there's this note that these equations, KFRE-like equations, may not be useful in people with earlier stage of disease. So just a reminder on KFRE, now part of the German primary care guidelines, but also a part of the UK guidelines, the Ontario and Alberta CKD pathways, and the KDIGO guidelines. The thing that I'm the most proud about is that we have 200,000 plus users annually on kidneyfailurerisk.com. And the users range from every country in the world. There's usage in Bhutan, in Nepal, in Sudan, in the DRC. So no matter what country in the world you think, there's somebody that's used the KFRE there to stratify risk. Our goal is to really move from an eGFR-based paradigm to a risk-based paradigm, to start thinking about a KFRE risk of 3 to 5% over 5 years instead of eGFR 30 to 60 to base decisions, to start education and introduce professional care when KF risk is greater than 10%, and to start fistula planning when kidney failure risk is more than 40% over 2 years. KFRE is implementable everywhere. In Ontario, Life Labs, Dynacare, and Alpha Labs all report KFRE. This is EMIS, the largest primary care EHR in the UK. And the risk of kidney failure, here's what you see here. As long as there's a GFR and an ACR present, EMIS will report KFRE for everybody. EPIC, which is a dominant electronic medical record in the US and in many parts of Canada, including Alberta, there's a dot phrase, which means that if you type in EPIC, .KFRE2, .KFRE5, and if the patient has GFR and ACR, KFRE will automatically populate into your clinic note. So these are the things that Adira was alluding to, the working with labs and EHR providers, which I've been doing over years, that have helped in knowledge translation. At Hopkins, they've gone a step further, and they've put KFRE as part of a dashboard for everybody with kidney disease. They also try to find cardiovascular risk, and they map out ACE, ARB, SGLT2, MRA, and GLP-1 usage so that you can see for my high-risk patients, do I have them on the right therapies? Now, one question that often comes up from users of the KFRE is, what does it mean for time to kidney failure? So probabilities are sometimes not easy for patients to understand, so you can frame things in terms of time. And in this study with CK Dobbs, we showed that a 10% risk equals on average 5 years to go till kidney failure. This is a 2-year risk. A 2-year risk of 20% means 43 months. A 2-year risk of 40% means 24 months on average with a range of 12 to 41. And a 2-year risk of 80% means 8 months. We start planning for a fistula here because 1/4 of patients at 40% or higher will progress within 12 months, and we don't want to miss people. And that's absolutely the right thing to do. This is data from Atik, helped by Adira and myself, looking at vascular access decision-making. Really very powerful to show that this 40% threshold for fistula leads to more fistulas that are actually used and less fistulas that are actually never used. So it optimizes on both ends of the equation. More people start with a fistula, and 13% fewer people have a futile access. I wanted to highlight some new updates we put on kidneyfailurerisk.com. So first, if you haven't been to the website in a while, or if you've been, you may not have noticed that it says calculators with an arrow on top. So every equation we build now in our research program will be added to this calculator section for KFRE. And also will provide interpretation, which I'll show on the next page. And we've created a new site, which I'm going to share with you in a minute, which is meant to help guide the benefits of early intervention. On the interpretation page, you'll see the KDIGO guidelines, which are practical points for clinical use of the KFRE, but you'll also see all the evidence that's generated, not just by us, but by other people in UK, Sweden, Europe, India, validation studies of the KFRE and studies of its use in clinical practice. So we tried to really put it all in one place so that people can get what they need to do to use the equation. So now let's talk about moving upstream, because that's really the big purpose of this talk, is to talk about why we should act earlier. So if you look at a 50-year-old person with diabetes, and they've got an eGFR of 80 and a gram of albuminuria, their KF risk or KFRE risk is 0.07% over 2 years and 0.2 over 5 years. In contrast, their CKD progression risk is 10% over 3 years. What is CKD progression? CKD progression is 40% decline in GFR or dialysis. If you imagine this person who's starting with an eGFR of 80, if they go in 3 years to 48, that's quite a bad outcome. And it turns out that if you have this bad outcome, you then have a 20-fold higher risk of dialysis. It also turns out that this outcome is accepted by the FDA, the EMA, as a surrogate for kidney failure. So a lot of the SGLT2 trials and upcoming trials in kidney disease have been based on 40% decline in eGFR. So it's really the appropriate outcome for CKD progression, and in every sense, it is CKD progression. This slide, or a version of this slide, you may have seen many times. We know that if we act early, if we act at an eGFR of 70 or 80, we do much better for patients than we act when we do an eGFR of 30 to 40. And that's not just preventing dialysis, it's avoiding transplant, avoiding reducing cardiovascular death, preventing AKI, and a whole host of benefits. So this is a static slide, and it's hard to pull up in front of people, and it's hard to use that for education. And I think this kind of early intervention is really very important in the multi-drug era, when you're thinking about RAS, SGLT2, MRA, and GLP-1. So with that in mind, we wanted to create another decision aid to show the importance of acting early. So I'm going to stop sharing for a minute, and I'm going to share the decision aid that we've developed. That's public as well. So here we go. Okay, so this is, I hope you can see it, is on actearlyonkidney.com. So anybody can use it in their clinic. And this is, I find it very useful when I'm talking to a patient about taking drug number 3 for kidney disease. I find I'm able to convince a lot of people to take their RAS and SGLT2. It's kind of become foundational therapy. But the next drug often begets a question. And normally I'll go through something like this. So we'll go to begin the activity. and I'll estimate the risk of CKD progression. And let's choose a high-risk patient, because in nephrology, we only ever see intermediate or high-risk patients. Low-risk patients never make it to us. And I show the patient what their trajectory would look like on a RAS inhibitor, RAS and SGLT2, or RAS, SGLT2, and MRA. So let's pick the third drug. And now I'm talking again about nephrology practice. So we're often seeing people late. So late intervention, this is around an eGFR of 40. We chose 40 because that's when most people see a nephrologist. 80 is in primary care. So what happens is you can show this patient that even if you start late, multi-drug therapy can delay dialysis by 14 years compared to no treatment, and it can lead to a 65% reduction in heart failure hospitalization. Now, if you take that same patient and you switch late to early intervention, it's 29 years with dialysis onset when compared to no treatment. And you can go through all the different options, late or early, RAS, SGLT2 or MRA, and intermediate and high risk. And you could walk through your patient the importance, particularly for high-risk people, to choose multiple therapies to slow kidney disease progression and the importance of acting early. So stopping there and going back to the slides. I still haven't worked out. I'm not sophisticated enough to go back and forth. Perfect. Okay, so the reason to do this is because if you just rely on providers to identify people who are high risk, they tend not to do that. This is the very first slide, but I will share multiple slides in this talk that show that we do not prescribe according to risk. So this is data from Canadian Primary Care Sentinel Surveillance Network, primary care practices. High-risk people have an equal likelihood or less of having good blood pressure control, statins, RAS inhibitors, SGLT2 inhibitors, compared to low-risk people. And we just don't see it, so we don't treat accordingly. So what I wanted to do was solve this problem, but really solve multiple problems. Here is what I think are the three big gaps in care. The first gap is that we don't order the right tests, unfortunately. What I mean by that is we order an eGFR, but we don't order a urine ACR. And when the eGFR returns normal, we say everything is fine. The second gap is that even if we order the ACR, we don't interpret the ACR appropriately. So this is, again, stuck in an eGFR or a creatinine-centered view. The ACR is abnormal, but you don't consider this as CKD because the eGFR is normal, and you don't do the right thing. Step 3 is that you recognize that this is CKD, you recognize the ACR is abnormal, but you only start a RAS inhibitor, and that still happens quite often. And so the treatment for CKD is at foundation, at baseline is RAS and SGLT2. So those things don't happen and the right medications don't get initiated. So our goal was to develop a test that would close all three gaps, that would make sure that both eGFR and ACR are ordered, that they're interpreted when they need to be interpreted as high risk, and that the dots are connected to the right therapeutics. So let's keep that in mind as we continue on. So we built new models to address these three gaps in care. We built the models using lab data only to predict 40% decline in GFR or kidney failure, which I mentioned is the FDA endpoint for CKD progression. And what we're using is a CBC, a chemistry panel, and urine ACR. So only a CBC, only a chemistry panel, and only urine ACR, no other biomarkers. We started out by developing this in Manitoba in 77,000 people, then validated in Alberta, then in Canvas, Credence, Fidelity, and then in 4.6 million Americans in Elevance, and then 1.1 million Americans in Optum. So today, altogether, almost 6 million adults, this score has been validated in. So first data from Canvas and Credence. So you can't use the KFRE in earlier stages, so all we could compare to was eGFR and ACR. So if you compare to eGFR and ACR alone, there's much more precision with the model. So 81 to 88% AUC versus 74 to 83. These are big differences in AUC as you get closer to 0.8. And not only that, in 6 months, the treatment group, the SGLT2 group's risk goes down over time, and the placebo group risk goes up. By month 12, there's like a 20% change in risk between drug and placebo that you can already see. I bring this slide up because I don't want to in any way allude that some patients benefit and others don't benefit from SGLT2. So this is data from the SMART-C consortium, the meta-analysis, that shows that if you treat 1,000 people for 1 year, let's take this example of people with diabetes, that you'll prevent 11 kidney failure events and 11 CV events. So the cardiorenal benefit is quite large, and the number needed to treat for cardiorenal events is 32 to 46 to prevent a single event. But what I do want to show is that this number is distributed according to risk. So if you use our test and you find somebody who's high risk, and let's say you find 4 people that are high risk, well, the number needed to treat for a cardiorenal event in that group is actually 4. So for every 4 people that are identified as high risk, you prevent 1 cardiorenal event, 1 CV death or heart failure or CKD progression. And even the KDIGO heat map, even just looking at the very red people, that number needed to read is 12. In intermediate risk people, the number needed to treat is 32 to 46. And in low risk people, the number needed to treat is about 120. Again, everybody benefits, but in high risk patients, there's no debate. Every high risk patient deserves treatment with 2 to 3 to 4 drugs, and that's the point we're trying to make. When you look at slope, high-risk patients on RAS inhibitor alone have a slope of -6. With drug, they have a slope of -2.8, with a net benefit of 3 mils per minute. Intermediate risk patients, 2 mils per minute, and low-risk patients, 1 mil per minute. And again, 4 for the combined cardiorenal endpoint. I put the cardiorenal endpoint on this slide because people often ask us, do we predict cardiovascular risk? And I would argue that you don't need to. Patients who are high CKD progression risk also are high cardiovascular risk. So just treat people who are high risk for CKD progression, and you will automatically capture cardiovascular risk reduction because the therapies are also all the same. Who are these people? So let's look at categories of albuminuria, really finely cut out. So here, A3B is a urine ACR more than a gram, so 100 milligram per millimole or more. Everyone in this category is high risk. No one is low risk, and almost everyone is high risk. And that's because you don't need a prediction equation to tell you that people with 100 milligram per millimole of albuminuria or higher are high risk. But as it turns out, all the way from 0 down to 100, including 3 to 10, 10 to 30, and 30 to 100, 1 out of 4 individuals are high risk, and 2 out of 4 here are very low risk. So all the way in that microalbuminuria category, where the vast majority of people with chronic kidney disease are, 1 out of 4 of them will have the same risk as somebody who's like got 600 milligrams of albuminuria, and 2 out of 4 will have exceptionally low risk, actually, of CKD progression. So where you need prediction equation is in the much larger group of people with microalbuminuria and somewhere between 300 to a gram of albuminuria. Above a gram, everybody's high risk. And this point is made here where, even in greater than 300 milligrams per gram, there's 8-fold less people than people with microalbuminuria. And if you extend this out to a gram, it's like 20-fold or 40-fold. Many of you who are enrolling in clinical trials of drugs that treat CKD, all these trials are looking for people with more than a gram of albuminuria. It's very hard. Not many of those people exist. Just wanted to share this data from Fidelity. So in Fidelity, which was a higher risk population, the model still outperforms eGFR and ACR, and it actually outperforms other models of CKD progression, which I will also share. Are these models disease agnostic? Kind of like what we see in with the KFRE. And yes, they are. This is data from DAPA CKD showing prediction in non-diabetic kidney disease and in the subgroup of patients with IgA nephropathy compared to eGFR and ACR. And what you would see here, I would argue, is that in diseases that are always on, not diseases that are relapsing remitting, like membranous or minimal change disease, in diseases like IgA and in diseases like probably like FSGS, models that use lab data are highly accurate. Even in children, this is data from CKD, these models are highly accurate compared to GFR and ACR. And children, as you know, have very different kidney diseases than adults do. So again, we find in diseases that are always on, lab data is incredibly predictive. Sorry, skip 2 slides here. This is a slide on a validation of this model in 1.1 million people. And the reason I wanted to show this slide is the extent of follow-up. Now, the numbers start to get small as we continue on, but even 15 years out, I want to show the predictive value of a single CBC chemistry panel in urine ACR. So a CBC chemistry panel in urine ACR done here turns out to be predictive 10 to 15 years later. Even a decade out, 44% of people have progressed to kidney failure in the high-risk group from a CBC chemistry and urine ACR that was done a decade ago. And I think that that's quite powerful, and it shows that you don't even need longitudinal trends in lab data. Even single time point lab data can be incredibly predictive. And my whole career is kind of based on lab data-based prediction. So I was very happy to see that. The other reason I bring this up is even in this million-person data set, RAS inhibitor use, SGLT2 use, GLP-1 use was not higher in high-risk people than low-risk people. And this and other studies have shown the massive gap we have in undertreatment of high-risk individuals. Not only do we undertreat people for high risk of kidney disease, we actually are more likely to discontinue therapy. So I think what happens is that if you're high risk, you tend to have more blips in your creatinine or kidney function, and these blips lead to unnecessary discontinuation. Now, as I mentioned, there's a combined cardiorenal benefit, and that cardiorenal benefit exists both for hospitalizations and for costs of care. So this is a study we did in 14 countries, Japan, Sweden, US, Canada was included as well. And we found that if you have kidney disease, all your costs and risks are driven by CKD and heart failure. So now circle back to the drugs that you would use, RAS inhibitors, SGLT2 inhibitors, MRAs, and GLP-1s. All those drugs treat CKD progression and heart failure. So you get a dual benefit by treating people who are high risk. So how do you actually make this happen? So we've created this test, as I mentioned, that bridges all 3 gaps of this in care. In Ontario, this has been available through Life Labs, and soon it'll be available through Life Labs in BC. It's a panel called the ClinRisk panel, and when you order it, your patient will go to Life Labs and have a CBC, chemistry, and urine ACR done. And if that patient is high risk, you'll receive a report that shows that this patient has 60% risk. It's shown in red. There's stick figures. This is just a data visualization work to make sure that you really understand that this patient is high risk. So that's the top part. So now you have the right tests are ordered and the right interpretation has happened. Now, what about the treatment gap? What we've done is we've mapped all the patient's labs, that same CBC, the chemistry and urine ACR, to the KDIGO clinical practice guidelines. So it'll take the lab data, match it to the guidelines, and it'll recommend a frequency of monitoring, a blood pressure target, whether referral is indicated per the provincial pathways, are there any complications of CKD, and are there any disease-modifying therapies recommended to treat CKD progression. So you're trying to fill those 3 gaps in care. You're ordering the right tests, you're interpreting them with risk prediction, and you're connecting the dots to treatment. So why do you want to do this? Well, we think that there should be a risk-based implementation for GDMT for people with CKD. Not today, it's diabetes and CKD, because we don't yet have trials of MRAs and GLP-1s in non-diabetic kidney disease. But you could see how this would extend out to all CKD very soon. So if you take 100 people with chronic kidney disease, let's say, about 50 of them will be moderate or low risk and could be managed with a RAS and SGLT2 and largely managed in primary care. And as risk goes up, therapy should go up. So for the next 30 who are yellow and orange, they might need 3 drugs. And those 3 drugs could either be an MRA or a GLP-1, depending on if they're obese, perhaps they get a GLP-1. And if they are lean and they don't have glycemic control issues, they get an MRA. And for those who continue to progress, for those at the highest risk, they might need 4-drug therapy and earlier nephrology referral. So it's really, the goal is to align treatment with risk. Now, what's happening today in practice? Now, I said foundational therapy is RAS and SGLT2. So even foundational therapy is not happening. This is data from the VA in people with CKD. So in the VA, in the US, there's very little cost for SGLT2. Similar to Canadian costs, any veteran can have access to SGLT2. But even in people with diabetes, CKD, and atherosclerotic vascular disease, only 11.5% of veterans received an SGLT2. And actually, the bigger the disparity, the less likely you were to get a drug. And again, discontinuation rates were highest in people at highest risk of progression. So we continue to have this risk treatment paradox that we see in every healthcare setting. What about Canadian data? I've seen data from Alberta. Alberta publishes a very nice CKD atlas. And if you look at the latest atlas, in people with diabetes and CKD only, so you can imagine the number would be lower in non-diabetic kidney disease, people who have an obvious indication for SGLT2, the use is 27% in Alberta. And my feeling, and I'll support this with data, is that if it's 27% in the entire population of Alberta, it's 27% in high-risk people, and it's 27% in low-risk people. And I had always sort of felt this, but we felt we needed to show it. So what we did is we did a project with the largest nephrology practice in the US. And now this practice has 45,000 patients in 150 nephrology providers plus, okay? And what we took is we risk stratified every single person in the practice at a provider level and a patient level. And we said, if your patients are high risk, what's the association between SGLT2 use and risk of progression? And you can see there is absolutely no association. So whether high risk patients are not any more likely to get an SGLT2 than low risk patients. And again, in this nephrology practice, the average was about 30%. So the reality is that we treat 30% of patients with the appropriate therapy. And even in people with a number needed to treat of 4, even in the people where there's absolutely no debate, we still only treat 30% of patients. So who's doing the right thing? Well, actually, you just have to be a doer. What we showed in the same practice is that prescription of SGLT2 was strongly associated with prescription rates of RAS inhibitors. So there are providers amongst the audience here today and amongst any audience that I present to who treat their patients. So either you treat your patients or you pass the buck. And if you treat your patients with RAS inhibitors, you are likely to treat your patients with SGLT2 inhibitors, and you're likely to treat your patients with MRAs or GLP-1s. And if you don't treat your patients, if you pass the buck to another provider, you don't do it, no matter what the risk is, or no matter what the usage is. So I would urge that all of us need to become doers and need to prescribe therapy, especially for high-risk individuals. Now, our hypothesis is that when you highlight risk, when you show a physician that this patient is high risk, they become a doer, that it enables them to prescribe. And we showed this in another large US practice. So this time, 20,000 patients, 32 providers, what we did is we put a flag in the chart in the EMR for high-risk patients. And in 18 months, we saw a tripling in SGLT2 use and a near doubling in MRA use in high-risk patients only. So the only people we flagged were the high-risk, high-slope number needed to treat of 4 people. And people respond. Because I think intrinsically we want to do the right thing, but clinical inertia gets in the way. I think you need to go beyond that, though. And what we are doing to generate more evidence beyond the validation studies is payer budget impact models, ICER models on cost effectiveness of risk prediction. We're doing clinical validation studies in India, in Singapore, in Southeast Asia, because I think in every population, just like in the KFRE, there's a UK KFRE, there's a Sweden KFRE. You have to validate locally for broad implementation. We're also doing prospective studies to measure impact on costs of care. And then we're doing a randomized trial in primary care clinics where if you have just albuminuria, normal GFR, either you'll get a flag in the chart or you'll get a high risk alert for your high risk patients with the report and all the clinical decision support. And in this trial, we hope to show that showing a physician, someone who's high risk, and the orders they need to do, bridging all 3 gaps leads to an improvement in quality of care and clinical outcomes. The reason to do all of this is it takes 17 years for research to reach practice. I am an example of this. We published the KFRE in 2011, and it took until the 2024 KDIGO guidelines to truly translate it into clinical practice. So 13 years. Only 14% of research reaches a patient, and most people are not going to use the evidence we generate unless we make it very easy, unless we make it so easy that it's a part of workflow and we close all the gaps for them rather than relying on them to do it. So this is a problem that I've been trying to solve all my career. I do want to highlight other models because I think it's important to have a message that we risk stratify and not necessarily risk stratify using tool A or tool B. The guidelines follow this, and I totally agree. So there are free models for 40% decline. They're developed by myself and Morgan Grams in the CKD-PC. These models also tested in millions of people across multiple cohorts. Now, they require medication use, history, smoking status, and physical exam variables. They're not just based on lab data, and their accuracy is about 0.74 to 0.77 in similar cohorts. What is nice, though, is that these models were linked to US NHANES data by other investigators, which showed a phenomena that we think exists also in Canada. So this is US data from NHANES. Based on the models developed by Morgan and I, other authors, so this is Tariq Shafi's work in Texas, they think there's 8 million US adults. So if you imagine there would be 800,000 Canadian adults who are actually high risk, and about 1 million Americans and about 100,000 Canadians who do not even yet have CKD today. And this is the big group. 16 million US adults that have a preserved eGFR greater than 60, and 1 out of 4, exactly 1 out of 4 are high risk. And that's the whole point. It's the 1 in 4 with microalbuminuria, normal GFR, who are actually high risk, and you wouldn't find them without using a risk prediction equation. And of course, they also show that there's 10 million adults with 6 million with CKD stage 3A in the US, and 94% of them are actually low risk. So these authors recommend that you use a prognostic tool across the entire spectrum and find people much earlier in their journey. Find these 4 million high-risk people when their eGFR is preserved. There is models from Alberta in late-stage kidney disease that predict death and dialysis. We've also built models for death, but I would really caution people using models for all-cause mortality. The Alberta KD Predict models and our models for mortality all have AUCs of about 0.7 for mortality. 0.7 is not good enough for individual patient decision-making. You should not tell people what their risk of death is from a 0.7 model. No patient has ever asked me in my practice, what's my risk of death? And I think that, yes, low risk low-risk older adults may benefit from a extended criteria donor discussion. High-risk older adults may benefit from an earlier discussion of conservative care pathways. But absolutely, I would never stop preparing someone for kidney failure because they had a high risk of death from a model with an AUC of 0.7. In response to consults I used to receive, we did develop a kidney cancer risk equation. So this is for people who are facing a partial nephrectomy or radical nephrectomy and they have CKD today. So if you have kidney disease today, you don't want to be on dialysis after your nephrectomy. And we built new models to predict exactly this. They're built on the backbone of the KFRE, so age, sex, GFR, ACR, and they add diabetes and type of nephrectomy. And we're now validating them in 6 countries to show that we can predict the likelihood of dialysis post-nephrectomy. It's also important for me to highlight the AHA Prevent tool for predicting cardiovascular events. So those of you who have not done it, this is available online. You just Google AHA Prevent. These equations incorporate kidney function and urine ACR. The really nice thing about this model is it actually also provides a 30-year risk in addition to a 10-year risk. So why is 30-year risk important? So I used to think that 30-year risk is like, who cares about 30-year risk? And then I turned 45 and I started to care about 30-year risk. So for someone like me, for example, I can enter my data into the AHA Prevent tool, and I can find out that I have let's say a 7% risk of cardiovascular disease in the next 30 years. And if I take a statin, that risk will be 5.6%. And now it's up to me if I want to take a statin for a 1.4% absolute risk reduction over 30 years, but at least I can make an informed decision about what I need to do. And I think what we're really all trying to do is move things upstream, get you not to take drugs in your 40s and 50s if you don't want to, but at least give you the information you need to make an informed decision much upstream. There are people among us who will do that, and there are people who absolutely won't do that. But at least now you can make an accurate, quantifiable decision. And this is, again, it's an online calculator. Use it, play around with it. And it's great that it uses GFR and ACR. So in the last couple of minutes, I want to emphasize my key take-home messages. CKD still very much follows the CGA framework. Pause is critical. eGFR and albuminuria are really important. That staging has not changed. But what we need to do now is not stop at staging. Staging is only the beginning. Risk stratification can follow staging. And now you can risk stratify for a number of things. With eGFR and albuminuria, you can identify risk of progression. You can identify risk of kidney failure. You can identify risk of cardiovascular disease. For kidney failure, please continue to use kidneyfailurerisk.com. We will continue to keep it updated and always add new information. We've now built new models, CKD-PC models, kidney clin risk models that can help you estimate progression and act upstream. It's really, that's probably my most important message for World Kidney Day, is that we are in an era of thinking less about kidney failure, dialysis, transplant, and much more about prevention of CKD, or certainly prevention of late-stage CKD. I like the Prevent tool. I think the 30-year risk is really valuable, so I'm happy to endorse it. And really, what are these tools all trying to do? What are we all trying to do is to match intensity of therapy with baseline risk. If you match therapy to risk, you'll have the lowest number needed to treat, you'll have the biggest benefit, and you'll have the best cost effectiveness. So yes, my responsibility, your responsibility is to the patient in front of you. But if you think you have any sort of health system or health economic responsibility, that's an even more compelling argument to use risk prediction. The cost, the ICER, the savings per treated patient is just much higher in higher risk people. So with that, I think we're at 45, and I will stop sharing and look forward to questions.
Thank you. That was a lot and very inspiring, both in terms of the fact that we can do stuff about people earlier on and also how to do it. So There are over 85 people on watching and talking. They come from a number of different areas across the province and other places, including physicians, nurses, administrators, statisticians, etc. So I'm hoping that there are some additional questions. Daniel is no question, great body of work. And I think what perhaps this audience, especially in British Columbia, needs to know is that at the moment, the clin risk is not available. And Nav and I and others have been talking about how it will be available and what kind of education process we need. And maybe you could speak a little bit to rolling something out with or without both the GPs and others and patients and physician nephrologists knowing about it. And then Sean
Yeah.
also has his hand up, so he'll ask you a question in a moment.
So I've spent a lot of time learning about how like diagnostic tests or lab tests are rolled out, reimbursed, covered in Canada. So first, we don't really have a great pathway for diagnostic tests in the country. So if you think about a diagnostic test like cystatin C, which has 2 decades of evidence behind it, even the reimbursement for cystatin C is quite heterogeneous and variable in many parts of the country. So all diagnostic tests have to start out in Canada as private pay, and then eventually they move to like employer-based reimbursement with a goal to get public reimbursement. So the ClinRisk test will be rolled out as a private pay test initially. And to Adira's point, there's a need for education and interpretation and buy-in from providers on the utility of it. I think, everybody can have different opinions on the economics, the societal aspects of screening, and how private pay tests tend to get higher SES people who may be more worried. But clinical utility we sort of have to have some agreement and understanding that if somebody shows up at my office with a test report, do I agree? Or do I think that this is like erroneous or bad data? So I think the first thing you want to do is provide good data. For example, there in the test report, there's a column about referral. So you want to provide referral information that's consistent with BC referral guidelines. You don't want to provide in that column data from another province or another country. So which is why I think it's essential to have outreach to nephrology leaders and primary care providers. And we've only just been at the very beginning of that, had an initial conversation, but we hope I know one of the questions that came up in the chat was slide decks, and I'm very happy to distribute our slide decks and also present to primary care groups. And I think one of the things I always want to be mindful of and present is the freely available tools as well for risk prediction, and not to say that, you should use this tool. Say, this is a tool, here are other tools, and we just want you to use something to find patients early.
Yeah, so Sean, you've got a question, then I'll come back to another one that's written in the chat. So you can unmute yourself, Sean, and there you go.
Hi, Nav. Thanks for that. That's just a great body of work and like really impressive taking, the KFRE, as you mentioned, 13 years ago and taking it through clinical implementation and health services implementation in terms of risk stratification. I guess my question has to do with, can you describe more how you actually did the parts of your presentation where you explored treatment effect of different therapies based on levels of risk? There's different ways of going about that, and did you sort of extrapolate relative effects from trials to individual level baseline risk, or were you actually able to stratify clinical trial data based on baseline risk? And if you did the latter, did you observe any difference in treatment effect, any difference in relative treatment effect across levels of baseline risk, or do drugs give you the same relative benefit? It doesn't matter what your baseline risk is. It's just that the absolute benefit then increases.
Yeah, so excellent question. We did exactly what you suggested and said. So we baseline stratified. We calculated baseline risk for everybody in Canvas, Credence, Fidelio, Figaro, and DAPA CKD. We then looked to see if there was an interaction between risk and treatment. In every trial, there was no interaction between risk and treatment. So the relative effects were exactly the same in low risk and high risk people. And the only the distribution of benefit was completely along baseline risk. So if you were highest risk, you got the highest benefit. And if you were lowest risk, you got the smallest benefit, but everybody benefited, as a way to think about it. So we did, we just couldn't, in these CKD treatments, we just don't find a lot of risk treatment interactions. Now, I know you work in more in a different therapeutic area, like with immune treatments, you could potentially have risk treatment interactions because the side effects from potent immunosuppressive therapy are more probably carry a higher burden than like an SGLT2 inhibitor or finerenone, for example. Because so you want to be even more mindful, I think, in when you're dealing with potent immunosuppressants than in this work. In this work, it turns out there's no risk treatment interactions.
I mean, that's really interesting, right? To suggest that drugs work equally well across the spectrum of baseline risk is quite informative. I mean, obviously in IGA we've looked at predictors and some of the things that predict outcomes quite strongly, like scarring and low GFR, they don't really predict response to treatment. So you do see that similar effect, but they don't mean that treatment's better, like on a relative scale in people at higher risk. It just means that it works similarly, but gives you a bigger absolute benefit.
Yeah, so it's a great segue to sort of question that Suneet had. So mentioning that many patients have these meds stopped, is that sometimes appropriate to stop a medication? And then in the CHF clinics, there may be a poor utilization. I certainly, I think people have different experiences in different CHF clinics. And I guess it's again that risk of medication and how one communicates the fluctuations in GFR to other providers, which is the big driver. And in fact, we had a roundtable conversation with endocrinologists and cardiologists and some nephrologists yesterday, talking about how you mitigate everybody's nervousness about this fluctuation in GFR, which makes people stop medicines. Right?
So I think I agree. It's an excellent question. And I would say that often in the type of work that we do, we don't get to drill down to the chart to say, like, was it truly an appropriate discontinuation or not? We do see, so I can share some examples. If you look at creatinine changes after an initiation of a RAS inhibitor, let's say, we see a lot of discontinuation even at changes between 10 to 20%. So now we see somebody who starts a RAS inhibitor, then they have a second creatinine, and if the rise is 10 to 20%, there's a discontinuation. Now I can't tell whether there were other things happening, but we see discontinuation. I think one of the best things that was not a guideline recommendation, that was a practice point in the KDIGO guideline, was this very explicit statement that up to 20% fluctuation in eGFR is within variability, and up to 30% if you start a hemodynamic therapy. And I remember in the room spending a lot of time thinking about this and actually really realizing that, wow, this is really important. And I think that as the guidelines being disseminated, I really hope that every speaker spends some time on that slide and on that point, because I think that's one of the most important points in practice, that do not stop highly effective therapy from small blips in kidney function.
Yeah, and I think that's Suneet's point, is like that needs to be socialized a lot more, because there is that, fear of change in numbers. I think the other powerful data is the stuff that looks at the discontinuation or reduction in RAS dose relative to long-term outcomes, and that in those people, for whatever reason, that had their RAS stopped or lowered, they have, and the same with SGLT2s, actually there's similar data out of Alberta. Out of that data, like those people do less well if their drug is stopped.
Yeah, always. And there's hyperkalemia data on RAS inhibitors that's another lab fluctuation that happens, and then the RAS inhibitor is stopped, it's never started again, and people do worse.
Yeah, and same will happen with MRAs and other things. No, I think, hold on, there's another question in the chat. I think, yeah. Upstream identification, do you envision a role for population-based urinary screening prompting ClinRisk, or that education and practice evolution will lead to primary care using ClinRisk?
So one, for population-based screening, I think we need a trial. I think that we believe in it. My prior is very high on the utility of population-based screening, but I think the U.S. Preventative Services Task Force and I imagine Canada would do the same. They'll want us to do a trial, and I think we Canadians across investigators should really think about, can we do a trial of screening piggyback to colon cancer screening? So I've done a lot of exploration in my province, and I think the infrastructure is there to do a trial. And I think that we should, as a community, we could change practice around the world in Canada by doing a trial. So that's the screening piece. With regards to use in primary care, I think primary care colleagues will look for validation and guidance from their nephrology experts in their community, in their local community. So many of you are attending from different parts of the province. So they might hear about this test either from Life Labs or from presentations that they attend, and they'll probably want to ask their local nephrologist, like, is this valid? Should I use it? And I think that's I think knowledge filters down that way, and that's what I think will happen.
Yeah. And I guess it's important, like, for people on the call who are from BC to know that we are trying to figure out if we can work with people to make ClinRisk available, A, for free, and B, no matter which lab you go to, because I think that, after knowing that it works, but then also knowing that we need education, everything, it would be really nice if we could make it accessible, not to the worried, rich people who can afford it, but to everyone, especially those at risk who are at the most likely going to get missed because they are younger with higher GFRs, and they're not going to get looked at. And they're the ones that you're very much talking about. So I think we need a strategy for that, and we need to work on it. As you know, so for the BC folks, like we have some work to do yet on this and its availability or non-availability at the moment, and we're trying to work with all the various people to see how we can do this. Yeah. Other questions? I think we are. No, we're at the bottom of the hour, pretty close. So
Thank you.
Thank you very, very much for not only the thought and the way that you put the talk together and your excellent presentation, but also for all the work that you've done to get us to here, and really how helpful the prediction equations are, and the concept of prediction equations without being wed to one particular one. I think you were very clear making that point there. As long as they're validated in your population, that's what we want to do, and that's what we emphasized in the guideline as well. So
thank you. Yeah, I thank you for the opportunity to participate in the guidelines. I don't say that enough. It was the best thing, one of the best experiences of things that I've done over the years.
Great.
So thank you.
Well, okay. Thanks, everybody. Happy Friday.
Take care.